Oh, yeah, yeah. Yep. Hello, hello. I think I'm live here. I told you guys that this is my first time doing this and I'm a little bit technically challenged. So if you are seeing me and hearing me, okay, then pop something in the comments just so I know that this is all working. I think it looks like it's working from my end. I see my husband's watching from the living room, so that's good. Oh, yay. Okay. Brittany. Yep. Yeah, good. Okay. 34 people? Is that right? That's awesome. How's it going, everybody? It's kind of weird to know that I'm talking to so many of you, but I'm just talking to my computer. Oh, yay. Oh, somebody says they can't hear and see. Andrew says that. Check the volume. Like there's like, well, check the volume on your computer because I think that everybody else is able to see. So one thing as you guys are coming in, I'm going to mention this again, but the PowerPoint's going to be blurry if you don't change the quality settings on the video. So go to the lower right-hand corner. There's like a little gear. Click on that and then make sure it's on 720, I think, P. And then you'll get the full resolution video. Otherwise, you'll just be seeing like a blurry video. Let me start. Put my screen up. Oh, okay. I see Andrew. Sorry, autocorrect. I'm with you. Good. Awesome. We've got 82 people now. I'm just gonna talk for a minute and let a few more people, let a couple people come in and get started. I'm so nervous for this. This is my first time doing like anything live. I'm really excited. I'm excited you guys are here. I figured this would be a good little practice run for next week's workshop since I'll be doing this every day next week. If you guys don't know about the workshop yet, it's going to be at 9 p.m. Eastern time every day next week in the same setting. So Facebook Live. And I'll be coming in and doing like a little mini review of hematology topics, very similar to this. So this was a nice crash run for me to make sure that the tech is working. Thanks, Elizabeth. I am nervous. it's fun though. Who wants to see my cute dog? She needs a haircut. Does anybody else's dog need a haircut? Like whoa, yeah, she stinks. Her face is stinky. So she's keeping me company. All right, let's see, where are we at on time here? Couple minutes. As you guys are coming in, also tell me where you're from. If you're a vet tech, veterinary, anything, what you do, where you're from, if you're a student, and that'll be great to have and see. I may have a little bit of a runny nose during this because I live in Louisville, Kentucky, and everything is blossoming and it's beautiful, but it's horrible for me and my allergies. So forgive me if I'm drinking on my water and my coffee at the same time. All right. Poland, wow, yay, awesome. All right. We're 5 minutes in. Got 123 people, so that's awesome. So I'm sure more people will join in as we are getting started. But again, just for the people who just came in, make sure you go to the little gear at the bottom right-hand corner of your screen and increase the quality of the video. Otherwise, it's going to be blurry. So go to 720 because I think it'll default to auto, and then you'll just get a blurry screen the whole time and it won't look good. Okay. Let's start. You guys ready to start? So I hope you guys are having a good night. I think probably a lot of you know who I am, but my name's Dr. Kate Baker. I'm a clinical pathologist and the creator of the Coffee House group. I actually started this group about 2 years ago now. It was right when I started, well, has it been 2 years? Yeah. I work for Antech, so I work alone, and I just was seeing like really cool cases and stuff I wanted to share, and I was like, I'm gonna start a Facebook group to be able to share these things because my husband only can act like he cares so much. He's an emergency veterinarian, and I pull him in my office and say like, look at this cool case, oh my God. he's interested, but I was like, I'm a little lonely. I want to share this with people. So I started the group, and it's been awesome. It's been so awesome having you guys in there, and it's just been so much fun for me, and has evolved and become like a really awesome learning resource for everyone. So that's who I am. And I just wanted to pop in and just do this quick little thing on lymphoma, because this comes up a lot in the group, and where people are not quite sure how to diagnose lymphoma, not sure like what the rules are with that. And it follows different rules um, than other types of cancers. So I think it's really valuable to understand just the very basics. I mean, this is going to be a real quick thing about how to do that, how to diagnose lymphoma. So, oh, if you guys have questions as I'm going along, make sure you put them in the comments, because I will try at the end to just scroll through and see if I can answer some questions, as long as I am not like my brain is exploding, because I'm sitting here looking at my iPad at the comments and have a couple different devices around me. Okay, so we all know what lymphoma is. We also have seen it. And so here's kind of the basics for diagnosing lymphoma. Diagnosing lymphoma, no matter where you are in the body, so it doesn't matter if you're in a lymph node, which is where we most often think about lymphoma, right? Or the skin, or the spleen, or any organ in body cavity effusions, it doesn't matter. Diagnosis of lymphoma depends on one thing: the proportion of small to large lymphocytes. That's it. And I know I make it sound so easy, like, oh, that's it, like it's so easy. It's not always easy. They're not always clear. So even to pathologists that look at these all the time, we sometimes are like, ooh, I'm not sure about this one. So it's not like it's just so easy. It's just, that's what we are looking at when we're diagnosing lymphoma: the proportion of small to large lymphocytes. So sometimes people get confused and think, well, these other things that I have listed here on the right, those are criteria of malignancy that we all learn in school, like anisocytosis, which is different cell sizes, anisokaryosis, different nuclear sizes, multiple nuclei, so a cell has multiple nuclei, nuclear molding, so the cells are kind of hugging each other. Those are the things that we think about when we are considering criteria of malignancy. But those things do not apply to diagnosis of lymphoma. So there's an exception there, and it's an important exception because it can be really confusing. So you don't look at any of that. All you look at is the proportion of small to large lymphocytes. Okay, so how can you tell if a lymph node or a lymphocyte, I'm too excited. How can you tell if a lymphocyte is small or large? Well, you compare it to a neutrophil. That's the ideal cell that you want to compare it to. So if you have a lymphocyte somewhere in your sample, there should be a lymphocyte or a neutrophil somewhere. That's what you're going to use to compare the size to be able to tell if a lymphocyte is small or large. So here in this picture, you can see in the middle, there's a nice segmented neutrophil. And then the small lymphocyte here on the left is going to be smaller than a neutrophil. So when we're talking about size, usually we're talking about actually talking about the nuclear size. So here the nucleus is smaller than a neutrophil. And a large lymphocyte should be larger than a neutrophil. So usually the large lymphocytes they can be just about the same size as a neutrophil. So the nucleus is about the same size to larger than a neutrophil. Sometimes I'll use like intermediate to large and kind of clump those together. Basically just immature, so not a small lymphocyte. So intermediate to large is kind of like a catch-all term for those lymphocytes that are just big and immature, but they're not, but they may be like not gigantic. They're just bigger than a small lymphocyte should be. So that's how we can tell about size. That's how we gauge size. So in a normal lymph node, so a lymph node that is completely normal, not reacting to anything, it's just a lymph node, it's just there. Or a reactive lymph node, which is reacting to some source of antigenic stimulation. So there's some kind of antigenic stimulation happening in the body, whether that's infection or just inflammation of any kind or cancer. I mean, it could be anything. So, I mean, for me, like last week, my lymph nodes were super swollen. and it was because of allergies. So it's not an infection. It's just my body is reacting to an allergic stimulus or an antigenic stimulus. So that's when you get reactive lymph nodes. And well, at least I hope that's what it was. I mean, they've gone down. So thankfully, you know, I'm a little hypochondriac, probably like many of us in vet med, but they have since resolved. My runny nose, on the other hand, not. But anyway, so normal or reactive lymph nodes, they have a predominance of small lymphocytes. So over 50% of the lymphocytes there in that population are going to be small. That's the pattern for normal or reactive lymph nodes. Reactive lymph nodes may also have like an increased proportion of intermediate to large lymphocytes, but that's in comparison to a normal lymph node, but they're not going to exceed 50%. So in the vast majority of cases, there's like rare cases where you have super reactive lymph nodes and it might be straddling that 50% line with those intermediate to large lymphocytes. But usually your total proportion is going to be less than 50%, even though you may see them more frequently in a reactive lymph node. They should not exceed 50%. In a reactive lymph node, you also tend to have increased numbers of plasma cells. So keep that in mind. So normal or reactive lymph node, predominance of small lymphocytes. Just a quick point, neutrophils, they don't play a role in deciding if a lymph node is reactive or not. So sometimes I see people say, well, you know, this is a reactive lymph node because I see neutrophils. And that's not the case. That's not how that works. So if you see increased numbers of neutrophils, that means the lymph node is inflamed or it's draining inflammation from a local site. So inflammation is separate from reactivity. Not to be confusing, but usually when you have an inflamed or an inflammatory process happening and you do see increased numbers of neutrophils, typically the node is going to be reactive too, right? So you might see that little increase in intermediate to large lymphocytes, you might see increased plasma cells. But you can have a reactive lymph node that doesn't have any increase in neutrophils, that is not inflamed. So I hope that makes sense, because that comes up quite a bit. And it's important because the lymphoid reactivity just is independent of inflammation. That's a separate process. Okay, so here's a pretty picture of a reactive lymph node. And in this picture, you can see just what I said, that the majority of the lymphocytes here are small. So I happened to pick a picture that did not have a neutrophil in it, which is funny because that's what I was just telling you to use as a gauge. But just trust me that these cells here with the yellow arrow are small lymphocytes. So most of these guys are small. You do have these big mamma jammas in here. These are large lymphocytes, and there's another one here, another one here, and here. And so they're there, but you can see there's definitely not a predominance of those. So I'm not worried about those. Those are okay to be there as long as they are there in the numbers that they should be. And then here you can see that there's a plasma cell. So this one has, I think there's another one. Yeah, that one's a plasma cell too. Remember, plasma cells have that little paranuclear clearing, which is the Golgi body. Their nucleus is offset to the side, so it's an eccentric nucleus. And they have that nice dark cytoplasm, and usually more cytoplasm than a lymphocyte does. So we do have some plasma cells in there. And then we also have this fun thing. And what do you guys think that is? You want to put it? Yeah, good. Awesome. Mott cell. So Carolina said Mott cell, and you're absolutely right. So this is a beautiful Mott cell. And I did post last week, I think, of a picture of a Mott cell and what a Mott cell is. But Mott cells are present usually in really reactive lymph nodes. So you can see them in some other situations, but the most common times I see Mott cells are in really reactive lymph nodes. It's just like a super ramped up plasma cell. And all these little blue things inside are called Russell bodies. So really pretty, very nice reactive lymph node in this case. Okay, so that's reactive lymph nodes. Well, then what about large cell lymphoma? So in large cell lymphoma, you have a predominance of intermediate to large lymphocytes. So it's flipped. So small reactive nodes, mostly small lymphocytes, large cell lymphoma, mostly large lymphocytes. Again, it can straddle that line. It can be hard to tell, but if you see a predominance, especially if it's like over 80%, that fits with large cell lymphoma. So here's an example of large cell lymphoma. There are some ruptured cells on here that I want you to ignore. So like this thing is ruptured. There's no cytoplasm there. This is ruptured. I don't know what's happening there. Ruptured. But you can see like these big, beautiful, large lymphocytes here, and here, here, and here, and here, and here, here. And like here's a small lymphocyte, right? So that's lonely, and this, and this. So there are some small lymphocytes in there. This is a neutrophil that's sort of falling apart. Here's an eosinophil. It looks like an EO because it has some little pink granules. EOs and neutrophils are similar sizes, so I feel comfortable using the EO as a gauge too. So you can see that these big lymphocytes are much bigger than this eosinophil. So the predominant population here are large lymphocytes. So it's lymphoma. That's what it is. That's how we diagnose it. Without getting too much on a tangent, there are some scenarios where you may aspirate directly into an active germinal center of a lymph node. So remember those germinal centers, if you can go way back in vet school and think of your like histo class, these germinal centers or these germinal follicles will grow and expand, and you can have these areas that are just predominated by large lymphocytes in there. If you happen to aspirate directly into that, then you may actually be aspirating a reactive lymph node and getting mostly large lymphocytes. Usually in those cases, the pattern is more patchy. So when you're looking at the whole slide, you see like little pockets of large lymphocytes, and then everything else looks normal and reactive. So this is part of why it's hard to diagnose lymphoma like straight up from a single picture, and why pathologists are a little like, cautious about that, because, what if everything else looked reactive on the slide? But for the most part, if I saw this picture and I would say, if this is representative of everything else on the slide, then this would be consistent with lymphoma. Okay, well, what about small cell lymphoma? So small cell lymphoma is a thing, and you can imagine that when you have a patient with small cell lymphoma, they are going to have a neoplastic population of small lymphocytes. And so you may say, well, how can you tell the difference between a normal or reactive lymph node and small cell lymphoma? Because they both should have primarily small lymphocytes, right? And the answer is, you probably can't. So on cytology, this is a limitation of cytology specifically for small cell lymphoma. There are some subtle clues that you can sometimes see with small cell lymphoma that might clue you in to say, ooh, I think this might be small cell lymphoma versus a reactive or normal lymph node. One of those things that you see here in this picture are these little pseudopods coming off of these small lymphocytes. So again, here's a neutrophil to compare to, and all of these cells here are small lymphocytes. Well, you see this little pseudopod, and you're like, So that little pseudopod, the little projection coming off here, has been correlated with small cell lymphoma. I want you guys to be super careful though, because that can also happen with reactive lymph nodes or as like a smearing artifact. So I personally would never just straight up call something small cell lymphoma just because I saw that pseudopod. But if I saw a lot of them and clinical signs really fit, like I had an older dog that had a prolonged unexplained peripheral lymphadenomegaly, I'm going to be going, this very well could be a small cell lymphoma. But I'm going to recommend additional testing. So a couple things that you can do for additional testing are histopath, but we've got some better options that are non-invasive now. One of which is tissue flow cytometry, which I'm not going to go deep into right now because it's just a quick thing, but tissue flow cytometry is a molecular test to help you differentiate between reactive populations of lymphocytes and neoplastic ones. And then in the confirmed cases, they'll give you information about, is it small cell, is it large cell, is it they can give you some prognostic information, because our dogs with small cell lymphoma usually have a pretty prolonged survival time. They do not behave the same way as large cell lymphomas. So it's important information. I just love lymphoma. I'm like panting. I'm so like excited to tell you guys about lymphoma. and I have a baby. I'm 6 months pregnant, so I feel like I'm panting all the time. Okay, so take a breath. So that's small cell lymphoma. So if you have a patient, again, that you're like you aspirate a lymph node and either you look at it yourself or you send it into a pathologist and it comes back as reactive, but that doesn't fit with what's going on clinically, because like this dog has just had these, maybe not even gigantic, but enlarged lymph nodes for some time, and there's no dental disease. There's no really there's no tick-borne disease or any indication of why that's happening. And it's been going on for a while. Then consider this and do some additional testing to rule it out or in. Okay. So that was it, basically, in a nutshell. Reactive or normal lymph nodes should have predominant small cell population. Large cell lymphoma should have predominantly large lymphocytes. That's it. So I just wanted to give you 2 pictures, give you a little quiz. Okay, so for this first one, what do you guys think? Do you think this is reactive or lymphoma? And I'll say reactive or large cell lymphoma because I'm not going to give you a reactive or small cell lymphoma because, like I said, we can't really confidently tell the difference on cytology in those cases. I'm watching. Awesome. I've got comments coming in. Lymphoma, lymphoma, lymphoma. Perfect. Amanda, Helga. Awesome, guys. You're absolutely right. So this is lymphoma. And here's our neutrophil to compare size. So these lymphocytes all over here are too big, large lymphocytes. So that's the majority of the population here. All of these are large lymphocytes. Here's a really pretty mitotic figure that's kind of falling apart. But well, I'm getting a little on a tangent again, but don't use mitotic figures to help you diagnose lymphoma. The reason I say that is because you can have mitotic figures in low numbers in reactive lymph nodes. The lymph nodes are like a pretty active tissue, and so you might have mitotic figures in normal lymph nodes, but you certainly can see them in increased numbers with high grade large cell lymphomas. So if I see that, I'm like, ooh, and that's not a normal looking one. This one's about to divide also. But I make note of that, and it might indicate, if you see a lot of them, that it's just a more aggressive lymphoma. But I don't use mitotic figures to help me determine if something's lymphoma. I use the proportion of small to large lymphocytes. All right, this one. Is this one reactive or lymphoma? What do you guys think? Sorry, there's some crud on the slide here, so just ignore these spots. But all these little red things or kind of brown things in the background, that's blood. Some of these cells are ruptured, so we just have to ignore these that don't have any cytoplasm. But like we've got these cells here, and then these guys here. Perfect. So of course I did one of lymphoma and one of reactive, but you guys are right. So this is reactive. And the reason is because the majority of the lymphocytes present are small. And then we also have a lot of plasma cells in this case. So this one is very reactive. I've got tons of these pretty blue plasma cells. This one's binucleated. I mean, I don't know why. Like, if I just saw like one binucleated plasma cell, I don't think I'd get too worried about it. But yeah, there's a beautiful plasma cell with that nice little Golgi clearing there. So a really pretty reactive lymph node. And that's it. That's all I wanted to talk to you guys about. So I want to talk to you about more, but that's all I figured I'd pop in and touch on here with lymph nodes and just give you those guidelines, because again, it's different than the way that we diagnose other types of malignancies. So like with your carcinomas and your sarcomas, you're looking at things like anisocytosis and eukaryosis, all those things, but that is not we don't apply that to lymphoma. So it's an important distinction, obviously, because it makes a huge difference in how you're interpreting those particular processes. All right, do you guys have any questions? I'm going to look at my iPad to see. It's a little hard to scroll through. Oh, Carolina, I'm sorry, I think it's Carolina. tell me if I'm saying your name right. She said, I've been told never to sample from submandibulars because they're often reactive and not good for diagnosis. So that's a really good point. I would say that's true unless the only lymph nodes that are enlarged are the submandibulars, and then you need to sample those. Because you can have lymphoma in those submandibular lymph nodes that aren't affecting the other nodes yet. So if I get an aspirate of a submandibular lymph node that looks classic lymphoma, like it's wall-to-wall large lymphocytes, I feel comfortable diagnosing lymphoma in that case. But if there's, sometimes the issue is that you get this superimposed reactivity because the submandibular lymph nodes are draining the mouth, and which is usually gross. So you're going to have just kind of perpetually reactive lymph nodes, and it can start to complicate the diagnosis because you can just have this sort of mixed population, like you've had neoplastic cells and you also have some reactive, like you have plasma cells and that kind of thing in there, and you're just like, ugh. So I wouldn't say never to sample the submandibular lymph nodes, but certainly if you have generalized peripheral lymphadenectomy, then go for ones other than the submandibulars, just to avoid that potential confusion. All right, see if we have any more questions. Sorry, I know it's awkward because I'm just sitting here reading while you guys are like watching me. Awesome, wow, a lot of people from all over here. This is so exciting. For the workshop, I'm actually going to have since we're doing it at 9 o'clock, my son's going to be in bed. So my husband's going to be collecting questions and giving them to me afterwards, so I don't have to sit here like scrolling through them. So it'll be a little more streamlined for the workshop next week. Okay, Nicole has a good question. If you have a body cavity effusion and you have to spin it down to see the cells and they all look like large lymphocytes, but there's not that many, can you still diagnose lymphoma even though the whole sample is of low cellularity? Welcome to a pathologist conundrum. So that can be tricky. I don't love to just straight up diagnose lymphoma when I don't have a good cellular sample. So if you have an effusion, like say you have an animal that does have internal lymphoma somewhere, so it has like a GI mass that's shedding off neoplastic large lymphocytes into an effusion, but it's just not shedding that many, and then you may get a low cellularity sample, but when you look at the cells all together, so you concentrate, you can see them right there, and they're mostly large lymphocytes, then, you know, also in consideration of the clinical presentation, then I would probably feel comfortable diagnosing. It just kind of depends on how many cells are there. I'm certainly not going to make a diagnosis of lymphoma if I only have a handful of cells. I might say, I don't like that there's a predominance of large lymphocytes here. I'm worried that this is lymphoma, but, you know, maybe directly aspirate that mass so that we can see what cells there are there. Because you really shouldn't have like a lot of large lymphocytes in an effusion. So yeah, I might go as far as worried or like strongly suggestive of, or I might call it. It just kind of depends on how many cells are there and how the patient is presenting. Let's see, Amanda says, I know you'd need IHC or molecular testing to determine the exact type of lymphoma, but would you see a mixed population within the node? I'm not sure that I totally understand. Like if they're, you need IHC or molecular testing to determine like B or T cell. But that's sort of independent of the diagnosis. So like I can make a diagnosis of lymphoma based on the cytology, but I'm not going to determine whether it's B or T cell based on that. I'm going to suggest additional testing in those cases to get that information. So the same rules still apply as far as making the cytologic diagnosis, and then you can do additional testing to get that phenotyping information, if that makes sense. If I didn't answer your question, let me know. I'll do a few more questions. I don't want to take up too much of you guys' time, but this is kind of fun. I hope you guys are having fun. I'm having a lot of fun on my Friday. I mean, we can't, you know, maybe when all the restaurants and bars open back up and I'm not 6 months pregnant, I'll do like a live thing from my favorite brewery down the street. And, but right now, you know, this is what Friday is. Um, Amanda also asked, can you diagnose T-cell rich B-cell lymphoma from cytology? Will there be a mix of sizes in lymphocytes in those lymph nodes? So T-cell rich B-cell lymphoma is a particular type of lymphoma for you guys who aren't used to hearing that. And honestly, I don't have a ton of experience of having those cases, but from what I understand with those are usually, and I'm going to make sure that I'm telling you the right thing, but those usually present as a more mixed population, where you can have mostly small lymphocytes. They can be challenging to diagnose on cytology. So those you may need additional testing as well. So those could just look like a reactive lymph node from what I remember learning about T-cell rich B-cell lymphomas, but really good question. Okay, I think I've got most of the questions here. If I missed, let's see. I'm just going through cocktails and cytology. Yes, Alice, that's what I'm saying. I am like so ready to drink a dark beer, like dark. I'm super into dark beers. And I'm just ready. I'm ready to get out of the house and go do something other than sit in my house. But y'all had great questions here, and I'm going to go through them and make sure that I answer them all. And I can probably just put like together a little thing, like maybe email it to you if you're on my email list, or stick it in the chat or in as a post to answer the rest of your questions. I promise I wasn't ignoring any of the questions if I missed them. I'm just trying to scroll through a bunch of comments. But I hope you guys like this. If you guys liked this and want me to do more of these, I certainly am happy to. Maybe next time we could talk about inflammation in a lymph node and see, talk about like the different types you see, maybe do some cases, whatever. If you have any suggestions, let me know. But if you guys are not, if you don't know about the workshop next week, again, it's the Getting the Hang of Hematology workshop. It's going to be just like this, where I'm going to go over different hematology topics every day at 9:00 p.m. Eastern time in the US. So I know that for some of you, that's like the middle of the night. Please don't get up in the middle of the night to listen. I will definitely be recording them and posting them. All of the topics are now listed under the events tab of like in the group. So go to the events tab and you can see all the different topics and sign up for reminders if you want to be there for them. But I hope you guys are all able to be there. I'm really excited about it. I put everything together and it's all ready to go. So yeah, if you guys have any questions or anything at all, just let me know. This is my little dog Birdie, if you guys didn't meet her at the beginning. She's a cute little cavapoo. But yeah, all right, well, good. I don't really know how to end this, so I think I'm just going to say goodbye and thank you guys. And hopefully this all went well tech-wise, and let me know if you have any suggestions or comments or anything like that at all. Otherwise, have a good Friday and a good weekend.